Jeff, thank you very much for having me here today. It's a great honor. I wouldn't have missed for the world. I told your kids I have to be here. Thank you also for your very, very kind words. Jackie, full disclosure, me and Jeff has been love at first sight. I haven't trained with you, but definitely I do have picked up a few things from you. Some dress code, but mainly also to never give up. And when you came the last time to Strasbourg, a few years ago, and you definitely have to come back, after a very busy day of live surgery, both laparoscopic and endoscopic surgeries, you told me, you know, Silvana, very often you're the only girl in the room, very often the youngest one. Never let anybody tell you that you're not good at this, because you are. So thank you very much. Your kids were worried when they assigned me this lecture, that there was no link between endoscopic suturing and bariatric endoscopy and you. But there is. You always saw the need first, and you put the patient first. There is a big need in bariatrics. We are only, as surgeon, targeting 1% of the obese population. And we're doing something that is not very effective for patients because we are palliating in the most aggressive possible way. And it's just not working because they do see it at end-stage therapy. And we are palliating something that we don't understand. So we're using surgery to just cover maybe a tiny little bit of what obesity is. And so we need something that is disruptive or something that is less invasive. And we don't always do it right because patient can gain back weight, even when we are very aggressive. So there is a niche to fill. And if we can fill it with suturing, which is very surgical, I think we can be extremely successful. And that is why I'm just going to focus on suturing. Because when you have a needle, you can do many, many things outside and inside the gut. And we do have now different systems that allow us to be to do exactly what surgeons do, to pick tissue and to shape the anatomy the way we want, and to do it in a way that's going to not only work on weight loss, but also on comorbid condition solution. I'll start with this system because I think it's really surgical. It's the Overstitch system. It's a big needle. It's a 1.5 centimeter needle. And if you are a gastroenterologist who is not hanging out with your surgical buddies, well, you have a problem because this can fetch things outside the body and you have to know the surgical anatomy. So if you are one and you want to learn how to suture, come to the OR, scrub with us, learn together with us, because this is the way we're going to push the boundaries between surgery and endoscopy. And of course we have to do it in a way that is effective and it's going to reshape the anatomy in a meaningful way. And this is very effective because we are reaching for the very first time some numbers that are becoming interesting for surgeons. We're achieving about 19% of total body weight loss, and it does also have an impact on comorbid conditions. Because obesity is not just weight. It's not just a number, it's not just a BMI, it's a very complex metabolic disorders, and we have to take into consideration that we have to fix all these things if you want to treat those patients. And we also have to look at quality of life. So we wanted to compare how well we were doing with laparoscopic sleeve gastrectomy and endoscopic gastroplasty. We weren't doing as well in terms of weight loss, but we had the same impact on comorbid condition, and patients did better in terms of quality of life. So we talked about the quality of life of the surgeon, but I think we have to think also about the quality of life of our own patients when we make the decision to treat them. And it does stand the test of time. Up to 2 years is still there. This is one of my patients. I scope them every year, and here you see the stitches are still there. Why is that? Because it's a surgical stitch. It's full thickness. It's going to stay there and do the job. And if it fails, well, we can do it again. We can go back and resuture to enhance the weight loss. Also to treat patients that are too heavy to be operated. And if it doesn't work, or if we want to use it as a bridge to surgery, we can go back and fix it surgically. We are at both sides of the spectrum of the treatment. We can do endoscopically, and then we can go surgically. It's very safe, safer than surgery. But you have to know what you're doing, because if you don't know the anatomy, you can grab things that are better left far away from your stitch, such as the gallbladder. And so in order to understand what you're doing, you have to come to the OR, you have to use the same surgical principle, you have to learn how insufflation can have an impact on your patient, you have to work with the anesthesiologist, you have to understand how to position your patient, not on the side, but maybe on the back, to help gravity assist you and to prevent the anatomy from being modified. And you have to understand a few structures that you really don't want to hit. The splenic artery, the left gastric artery, the spleen, things that you can clearly see in the US, but are just there, and you don't see them if you're just looking at the inner part of the stomach. It's something that is easy to learn if you have a good mentor, and there are many good mentors in this room, but being capable of suturing is not always being capable of granting the patient the best possible treatment. So how are we going to speed up the learning curve? How are we going to teach this? Mentors and mentees, workshops, go to the OR, scrap together, of course. But also maybe there is something else. We all learn differently, you just said in one of the previous videos. I was curious, just as you are curious. I wanted to understand why surgeons who are experts always land on their feet. I wanted to solve the mystery of the falling cat. A while ago, a French gentleman, was interested in understanding why cats, when they fall from a height, they always fall on their feet. And if you look at the cat, you don't understand. Now, if you use chronophotography, you understand that he does a rotation that makes him land on his feet. How about we use the same thing to understand how people learn? That could be fantastic, because if we measure and we use metrics and we use captors that can actually measure the movement, we can understand that this is somebody who's an expert, and the little rubble that looks like a 1-year-old or a 2-year-old drawing is somebody who's learning. So we can add actual science to how we teach. We can use simulation that is patient-specific. So if we add student-specific and patient-specific, probably we can do a lot more in terms of education. And we have to democratize that. You have spent a lot of time teaching students in remote areas. This is a way that we are trying to fix the problem of dissemination of training. We design a plug-and-play simulators that you can use on your computer, that is low cost, that has an intelligent heart because it's based on what we do surgically. We're tracking both the student and the scope, and then we're injecting it into the simulation. And probably this will help us teach even more surgeons and also gastroenterologists flexible endoscopy. We can use artificial intelligence if you are not smart enough in order to understand if we do things better, we can create surgical fingerprints of what we do to get a better understanding on how we can enhance our success. And then the indication, if we go endoscopically, maybe we can start treating patients with prevention. We can really target a much larger population. We can do this in teenagers instead of giving them an operation. We could use suturing in order to fix surgical complication. And this is Lee, I'm sorry he's not here. I put this video for him doing an outlet restriction. And we can also fix surgical problems just endoscopically, acute and chronic, even things that we didn't think we could do, such as candy cane, for instance. So in conclusion, I think that bariatric endoscopy, surgical endoscopy, is here to stay. And I think that we can do more and more with this technique because we are preserving the anatomy, we are preserving the physiology, we can do it outpatient, we can do it under sedation now. And just as Jeff Wisdom is here to stay, I think endoscopy has a growing role in surgery, also thanks to you, Jeff. Thank you very much.